So yes, Dennis Opondo, as you've heard, I'm a health manager working at Kalobeyei Refugee Operation, which is essentially run by the Kenya Red Cross. I'll start just by shedding some light on what we do at Kenya Red Cross, specifically with regards to refugee health. So the Kenya Red Cross Society is an implementing partner of UNHCR, which is basically the UN agency that deals with refugee protection. And we support health service delivery in refugee settings across the country, especially in complex and protracted crises, which includes Kalobeyei, Kakuma, and Dadaab. So our roles include providing essential services, coordinating with partners, and supporting systems that respond to both immediate needs and longer-term health needs. So I'll specifically be biased towards Kalobeyei Refugee Operation because that's where I've been. Mostly our work focuses on improving access to healthcare, where we support continuity of care, and we work with the refugee communities to strengthen the foundations of local health system. So in this session, I'll dwell a lot. I'll share some of the experiences that I've had from Kalobeyei, what we've been working on, some of the lessons that we are learning and we have learned, and where we see opportunities to improve how care is delivered in the humanitarian context. So yeah, let's dive in. So I put this here just to bring into perspective how the refugee landscape is looking like, specifically in Kenya. So Kenya is actually the fifth largest refugee hosting country in Africa, and the 13th largest asylum country all over the world. And it continues to be a home to thousands of refugees and asylum seekers from East Horn of Africa and the Great Lakes region, as it has been for the past 30 years. So this is attributed to the geopolitical tension that has always been around this region. So this slide basically shows the data that we have currently as of 2025 March, where we currently are hosting about 916,294 registered refugees. Of these, 67% are refugees, and 31% are asylum seekers, while 1% is stateless people. So next slide, please. So this is also just for your information. So this is a segregation of population by origin. So in Kenya, we do have the largest population of forcefully displaced people from Somalia, and followed closely by, not very closely, by South Sudan, and then from DRC Congo, and then Burundi, then Ethiopia, and then we have some various nationalities, including Yemen and Afghanistan, Pakistan. So we have all of those refugees who are seeking asylum within the country. Next slide, please. So I just put this here because definitely we know this conversation will definitely end up around conversation about finances. So I put this this is from the UNHCR database. It's basically a budget and expenditure trend that shows how much or how the budget has been from 2014 to currently 2025. And from the graph, you can see that there's been a downward trend of the budget expenditure. from 2014 to 2015. The steady decline, with spending consistently falling below the allocated amounts. This is a reflection, this reflects the kind of limitation of a crisis-driven funding model, which we've always used, which is usually short-term and predictable, and most often insufficient for sustaining long-term health system in refugee settings. So as we shift from emergency response to continuity, this financial consistency sort of undermines the services like chronic disease care, maternal health, and community health workers support. And to truly imagine a refugee health system, we then must move towards a more stable, more integrated kind of financing, where we align our investments with the vision of inclusion and resilience of refugees. And this currently is championed by the Shirika Plan, which is basically an integration plan that was recently approved by the Kenyan president. Next slide, please. So yes, allow me to just set the scene and just to get a feel of what and how Kalobeyei looks like. So Kalobeyei is actually the first integrated settlement that we have in Kenya, and it's actually an extension of the famous Kakuma refugee camp. As you can see on the map, there is the red demarcation is Turkana County, and then from down going up, there's Lodwar, then there's Kakuma, and then there's Kalobeyei. So Kalobeyei is further north, actually 30 minutes from Sudan if you're driving, and it's situated in the northwestern part of Kenya. So it is a home to approximately 80,000 refugees and asylum seekers, and about 20,000 host community members. So this setting is a protected kind of setting, and has limited infrastructure, and it definitely has produced a fragile health system, because originally when it was being initiated back in 2016, it was designed for emergency response. But of course, now it's strained by the rising chronic conditions and long-term needs from the refugees. So it's also good to note that this region is situated in an arid and semi-arid region with seasonal climatic disasters such as drought, which is very frequent. We also have drought, which often leads to famine and flash floods. So of note is most of these conflicts, or some of this, a good percentage of these conflicts are usually climate induced. This is owed to the fact that most of, say, the forcefully displaced people who are moving from Sudan are actually pastoralists. And then if you know pastoralist, you understand that there's usually a very strong fight for pasture and areas where they can graze their land, which has recently made the area to be a bit more hostile. So the complexity of service delivery is also amplified by the mixed governance, including the UNHCR, the Ministry of Health, both national and county governments, and implementing partners. So I believe Kalobeyei is where emergency meets endurance, and where we've started to build something new. By one, we have actually advocated for refugee inclusion in national health strategies and UHC frameworks. So this is, as I mentioned, there's the Shirika Plan that has recently been approved, but for the past about 5 years, we've been on what is called the KISEDEP plan, which is the Kalobeyei Integrated Social Economic Development Plan. Additionally, we also, how we are building something new is we're also supporting multi-sectoral partnerships. This concerns protection, wash, shelter, education, and also disability rights. And we are also aligning with the Global Compact on Refugees and the 2030 Agenda on Sustainable Development, which anchors on the principle of leave no one behind. Next slide, please. So this is just a picture of one of our, actually one of our largest health facilities in Kalobeyei. So the Kalobeyei health system definitely has had a lot of challenges, again, because it was built for short-term emergencies, but is now under immense strain because of the growing needs of the protracted refugee operation. As I mentioned earlier, it's almost been 30 years since the refugee camp began, and Kalobeyei is an extension of what had begun 30 years ago. So these gaps have been worsened by severe shortages of health workers, recurring stockouts of essential medicine, and fragmented health data systems, which have made it very difficult to kind of manage the kind of health concerns that are within Kalobeyei. As you might all be aware, the situation has actually further destabilized by the recent suspension of US-funded programs, which has led to interruptions of basic services and operations, which clearly delineates a deeper structural issue that donor-dependent systems are fragile. So that means when external funding is paused or redirected, care delivery then stalls. So despite the health challenges in Kalobeyei, there is hope and efforts that are being made for a long-term solutions. And without a predictable investment into health system, continuity will definitely remain out of reach. Next slide, please. So yeah, this is just these are basically the building blocks of a health system as we have tried to employ the same in Kalobeyei. So in terms of governance, we've had a robust kind of teams working together. And at the moment, with the KISEDEP and the Shirika plan that I had earlier mentioned, UNHCR through the county and national government is moving from just refugee camps to a more inclusive municipality development, which then allows the forcefully displaced people to engage in business or to be able to be self-reliant or self-sufficient. And the government is also advocating for refugee inclusion into national health strategies and UHC frameworks. And this has been seen by the current development of the Social Health Authority or the Social Health Insurance Fund, which has actually been opened up for refugees. So now they can register to the national insurance system and they're able to actually get some of these services. This was previously not the norm, but it's something that is picking up amidst various challenges. So the leadership is also supporting the multi-sectoral partnerships. This includes WASH, shelter programs, education, and disability rights. And in terms of medicine and technologies, this is also somewhere that we have had a challenge because most of the essential medicine are just basic medicine. And usually we are not able to get the most or the very good medicine in this setting. But well, we hope that with partners, including MOH, which are currently very involved in the health of refugees, and also some other public and private partnerships, we're able to now procure more of this medicine and technologies. We're able to do things like X-rays and CT scans, which were not so common within the refugee setting. So we're also able to use standardized medical kits in emergencies. This is in cases of outbreaks or any kind of reproductive health services. And we are actually, because of the growing burden of chronic diseases, this basically the non-communicable diseases, we are having a lot of partners who are coming in to support the NCD program, which previously has not gotten much support because, I mean, NCDs is a long-term, it's a long-term health concern. So most funding agencies or most donors would not want to go that way because it's much more expensive. It's you cannot, it does not come to an end as previously has been done with more communicable diseases, which are usually treated and they go away after some time. So in terms of service delivery, we are now moving from having emergency tents and mobile clinics to a more integrated community-based healthcare, where we are building and renovating facilities. We are able to follow up and support immunizations, especially for zero doses. We are able to have our own sexual reproductive health centers, and we also have able to have like standard NCD clinics that offer differentiated kind of care. Additionally, we're also able to send some of the referrals to our links within the county referral hospital, which basically is the Lodwar Referral Hospital, because of these systems that we've put in place. So in terms of health workforce, because it might be expensive to actually employ qualified doctors, we are really leveraging on community health workers, and we are picking them from both the refugee population and also the host population. And this is because the community health promoters do understand the local culture, the local language, and if you want to actually treat this population well, you really need to understand some of their cultures, and you really need to build that trust for better uptake. So in terms of capacity building, we are working to build capacity of the clinical team that is there. And we're also working to build the nursing assistants and physician assistants who we are actually picking from the refugee community. And this task shifting and upskilling has really helped us to build some sort of resilience to the limited setting. So in terms of health information systems, we are now, we've moved into from just ad hoc data collection to a more integrated kind of data collection. And this has enabled us to just follow some of the trends and also follow up some of the clients who have been ill for a while or who are on long-term care. So we do have, for example, we do have Norwegian Red Cross who have currently been supporting us with AI innovations to help with outbreak detection, and also vaccination coverage and monitoring, which are also things that were not previously there, but they're now coming up. Next slide, please. So basically, this is what we've been talking about in terms of shift towards continuity. What has changed? What has changed is their health needs that have evolved from just acute to chronic, and we are seeing more non-communicable diseases. We are seeing more mental health conditions, and a lot of sexual and reproductive health issues that are coming up. And emergency response model is no longer efficient for long-term needs of the refugee population. And then there's a rising demand for consistency, follow-up, and integrated care. Now, this is especially at a time like this where most of, say, first world countries have reduced the number of immigrants or refugees that are seeking some sort of asylum or repatriation into their country, and a more sustainable approach where people are asked, or the refugees are asked to or are left within a certain area, but then integrated with the community, and they're able to pick up and continue their lives as usual. So some of the key strategies that we've introduced is integrating PHC or primary healthcare models to address both acute and chronic disease management. And as I mentioned earlier, there's deployment of community health strategy among the refugee population. So within Kalobeyei, we already have community health units with designated community health workers who have been, who are actually digitally equipped and empowered, and they're also incentivized so that they can be able to make the whole coverage within the Kalobeyei refugee settlement. And also, as I mentioned, we are also adopting the Social Health Insurance Fund for sustainability. So the partnerships that are driving this shift basically is UNHCR and Ministry of Health, both national and county governments, and health implementing partners, which include Kenya Red Cross and International Rescue Committee. We also are taking a lot from community leaders in this decision making, so they are definitely part of the shift. So there's a lot of groundwork for Shirika plans, inclusion, and sustainability, which we are currently leveraging on. Next slide, please. So I just put this slide because I strongly feel like the Shirika plan is one of the ways that we are shifting towards continuity, and we are hopeful that it will work despite some challenges. So Shirika plan basically means socio-economic hubs for integrated refugee inclusion in Kenya. But Shirika is a Kiswahili word that means organization or come together. So basically, you'd ask yourself, what is Shirika plan? It's a government of Kenya-led initiative that helps to transition both Dadaab and Kakuma and Kalobeyei refugee camps into municipalities. And the aim is to integrate refugees into national and county public services, including health, education, water, and housing. So the shift is basically from a humanitarian aid model to a development and inclusion model. So you'd ask yourself, why is this groundbreaking? Because for 30 years, it has been a refugee camp-based kind of care. And this kind of new model that we are moving to is one that embraces inclusion and it also creates opportunity for refugees, and it also allows refugees to be self-reliant, and it basically replaces the long-term aid dependency with socio-economic empowerment for refugees and host community. Then who are there to benefit? The people who will benefit most from this is definitely the about 1 million refugees who are currently within Kenya, and also the host communities that are with where these refugee settlements are. So that is in Turkana and Garissa counties. So this is particularly important to the refugee community because most of them live below the poverty line, which usually is about around $2 per day. So what do refugees have to benefit from this? So they'll be included in national education and health systems. They'll be given economic development opportunities. They'll also be able to work and get licensed within to work within the country. And this will also reduce the strain on host community by sharing the services and infrastructure. Because previously, some of these facilities have been specifically for the refugees, and the host communities have not been able to benefit. So how, again, is this Shirika plan supposed to be rolled out? At the moment is actually in its transition phase, and even as we speak, we are actually shifting some of our facilities from UNHCR led to county government led. So we're actually transitioning some of our facilities now to become public facilities. And this is supposed to run between 2024 and 2027, where we are establishing laws and redesignating camps as municipality and beginning the integrating services. And then the stabilization phase is supposed to run from 2028 to 2031, where we deepen the system alignment and scale up the implementation. And finally, within the resilience phase, which is supposed to be in 2032 to 2035, where we achieve full inclusion, economic independence, and also climate resilience. So, of course, this will not be easy, but I'm sure with a lot of support that we're getting from the government and a lot of political will, it's something that is achievable because it's been done somewhere else and it's worked. So this is also an opportunity for Kenya to move towards that. So the 6 pillars of the Shirika plan are basically system building, where we strengthen the county and national institutions to support refugees and asylum seekers. We are integrating services with health, education, WASH, housing, and waste management. We are building human capital. We are allowing economic development and also insisting a lot on climate action based on the fact that Turkana and Garissa are both in climate disaster prone areas. So, next slide, please. So what must we do? If we at all need this to work, we have to support community-driven health models like Shirika Plan. It's good that we've already initiated this and we are moving towards seeing how best it works and learning from what will fail and what will not. We also are prioritizing refugee inclusion into national health planning. So definitely we are trying to push so that in every conversation that regards health within Kenya, refugee inclusion or refugee as a conversation is always brought up. So we're doing this by trying to be part of all the conversations from the National Ministry of Health. And we're also investing in community health networks and digital tools. As I told you, we are now building community health units within the refugee settlement, and also building digital tools such as Ichis, which is basically the online platform where we look at community units and we try to see how many have received this. In case there's an outbreak, what are the chances that it would spread? What are the best ways to contain it? And having all these digital tools are actually helping us to be able to identify some of these outbreaks faster and even manage them faster. And we are also shifting from short-term aid and towards long-term system integration. Next slide, please. So this is also a picture of one of our CHPs called Donatien Kwizeru from Burundi, who has been for over 7 years has supported our TB screening and awareness in Kalobeyei. And she's very key because she's one of the CHP leaders and who have been helping us transform community health seeking behavior among the refugee population. Next slide, please. Yeah, so I think up to there, I could have talked a lot. There's a lot to say, but I just wanted to keep it short and sweet so that we can be able to engage further. So at this point, I'm happy to take any questions, any discussions, any suggestions. Over and back to you. Thank you.